describes our mission, which is to address the non-clinical factors impacting the health and well-being of our patients, and our mission to help every community and the people want to live its healthiest life. Our strategy for doing this is threefold. First of all, we want to think about what are the programs and collaborations at the neighborhood and community level that actually address some of the health-related social needs that people in those communities are experiencing. Secondly, we want to use what we're learning to educate both ourselves as well as the broader medical community about the importance of addressing health-related social needs. And finally, we really want to commit ourselves to research and evaluation. We start any initiative with the question, how do we know this is going to work, and how do we measure it? So that we can scale up what works and pivot from what doesn't work and contribute to the knowledge base around this work. The Institute for Hope sits within a much broader Population Health Innovation Institute at Metro Health. And you can see the different pieces of PHII at Metro. So we are in constant dialogue with other parts of the institution whose overall mission is to address the health of populations as opposed to individuals. So, and I see this very much as complementary to what Larry just talked about. That, you know, our commitment is to, as family physicians, is not just to the individual, but to the communities and the populations we serve as well. So this is our way of doing it. Within the Institute for Hope, we also organize our work into several centers, which you can see. By the way, these slides are all available on PDF. So there's a lot of information here. I'll go through it pretty quickly, but it's all on that. And happy to talk more with anyone about more of this anytime over the weekend. One of the tasks we were given by our CEO was to screen all of our adult patients for health-related social needs. Now that's a big task because we have about 180,000 people who are part of our receive primary care from the mental health system. So we conceive of this as kind of a giant PDSA cycle, if you will. First of all, we want to screen and use the screener that I'll talk about. Secondly, once we identify the needs, it behooves us to do something. So we are part of an electronic resource network that uses an electronic resource referral platform that allows us to make electronic referrals to community-based organizations based on certain needs, and then have them respond back to us electronically so that we truly close the loop around the social needs. And I noticed that on the paper Larry handed out, at the very bottom of the second page, it talks about exactly this work. Once we close the loop, we have a lot of information about what needs there are, what needs are being met, what needs aren't being met, and we can use this work to evaluate our impact. And I'll give you a couple of examples as to how that looks for us. We have EPIC as our electronic medical record. EPIC has a social determinants of health screening tool in it. We use that. We've modified it a little bit. We've added some connections about digital connectivity. Among Cleveland's many problems, one of them is that we are the least digitally connected large city in the country. And so we thought we had to address that as well in our assessment of health-related social needs. This is what the questions look like. Again, this is in the PDF I sent. It's several questions. It takes about 10 minutes to really work through this. And what we found is, in addition to asking the questions, once we've asked the questions, we need to ask people, do they want help? Because not everybody who reports a health-related social need to us actually wants our help. And we're actively sort of investigating why that might be. So it's not just, do you have health-related social needs, it's do you have them, and do you want help, and if so, with which ones? Because we have folks who might report a housing need, transportation need, utility need, but only want help with one. And so we really want to, help people the way they want to be helped. So in order to do that, we have to ask them what they want help with. And then finally, we ask them to consent to the electronic resource referral platform we use, which is called Unite Us, and the network we formed, which is called the Unite Ohio Network. We've done most of our SDOH screenings via our electronic patient portal, which we call Misak. Now, obviously, with a digital divide, that leaves a lot of people out, and we know that. But what we're struggling with, frankly, is the time it takes to get this done. And the more we can get done outside of the clinical encounter, prior to the clinical encounter, the less burden we're putting on our care teams, which, as yours are probably, we're all understaffed, right? And we're no exception. So we're trying to get this done in a way that doesn't impact the clinical care team as much as possible. However, we are looking at ways to get this done at the point of care. and we do have some options. Our least favorite option is a paper survey, because then somebody has to put it back into the EMR and just creates rework. But we're trying to use kiosks when people check in, when they're waiting for their provider or their clinician, their doctor. Also, Epic has this really cool feature called captive mode, which, you know, we all have a computer in our exam room, right? We can turn the computer over to the patient and have them complete a survey without violating any other kind of privacy anywhere else. So that's kind of, then we're just starting to learn what captive mode might look like. So we have some ways of trying to do this at the point of care. It's been a struggle for us. I'm hosting a breakfast table tomorrow. If anybody's in this space, I'd love to talk about how to get this done better at the point of care in a way that, again, it doesn't impact or intrude too much on the process. As of August, we've screened almost half of our patients for health-related social needs. Not surprisingly, since we're a public safety net hospital, 2/3 report some risk and about 20% report 3 or more health-related social needs. And this is how they map out for us. Far and away, the most common health-related social need revolves around social isolation. This preceded the pandemic, and it continues beyond the pandemic. We thought this was a pandemic-related phenomenon, but it's not. Certainly, the pandemic made it worse, but it didn't cause it. And you can see some of the other health-related social needs that patient reports. And most patients report more than one health-related social need. We also screen our employees anonymously, and this is what they're telling us. Social isolation is still a big deal for them. And you'll notice that some of the things around financial resource strain are still a problem with our employees. And we're committed to paying a $15 an hour minimum wage. But I think it just goes to show that a minimum wage is not a livable wage. And for a lot of people, we're still experiencing financial hardship, even fully employed. Because all the answers that people give exist in the EMR, they are reportable fields. So we can pull these out, slice them, dice them, compare them in a whole bunch of different ways. And this is just one example of how we're doing that. We're using a Tableau platform, and we have hopefully patent pending software that our analytics team has developed that lets us kind of, match things up. Okay, so what do we know about people? Gender, race, ethnicity, zip code, site of primary care, who the primary payer is. Again, we can slice and dice this information in all kinds of different ways. And we're just starting to figure out what to do with this. It's like a lot of data, and now we have to turn it into information and hopefully wisdom. All right. I'm stopped. Okay, so as I mentioned, once we screen people and they tell us they have health-related social needs, they tell us they want us to do something about it, it behooves us to try and help them if we can. So this is where our electronic resource referral platform comes in. There are several vendors in this space. Unite Us and Find Help and Bertha are probably the two most well-known, but they're not the only ones. My personal feeling is that these vendors are going to do for social care what electronic medical records did for medical care. So there are obviously some very good things and some not so good things about that. But think about the way we handle these things most of the time in our practices, right? Someone says, I'm homeless, or I don't have enough to eat. We send them to the social worker. Social worker gets a phone number out, writes it down, gives it to the person, and says, why don't you give them a call? Good one. And that's the end of it. What this allows us to do is, when a referral is sent to a receiving agency, a community-based organization, that organization in turn contacts the patient and engages them and tries to resolve the need, and then responds back to us electronically with how that need was met or not met. So it takes some of the burden off of the patient to have to navigate what can be a very complex CBO system, especially if you have more than one health-related social.
Jim, is that all through the Epic Center as well? All that communication, all that.
Epic, there's an electronic link between Epic and Unite Us.
Unite Us is a separate.
Unite Us is the electronic resource referral platform.
Okay.
It's a vendor product.
Okay.
It's like Epic is a vendor product, and we can link to it in our EMR. Subsequent upgrades of Epic are going to allow a more seamless integration. But right now, it's a link to a separate platform, but it's embedded in the EMR, so we don't need to wrap it. This is a schematic of what Unite Ohio looks like. A need is identified, a referral is placed. The shared technology platform allows the referral to go to the CEOs, who then address the need and respond back. The nice thing about these electronic resource referral platforms is they're not a hub and spoke with the healthcare system at the center. They're a web, they're a matrix. So if we refer someone to the food bank for food insecurity, and they then discover the patient's also housing insecure, they can refer them to CHN Housing Partners to get help with housing. So, and everybody is aware of what's being done for the person because the person is in what's called a master person index. So all of the CEOs and healthcare systems can see what's being done on behalf of the person. Obviously, this is with consent, with appropriate HIPAA safeguards. So they say. This is where we're at in Cuyahoga County. We have a pretty robust Unite Ohio network in Northeast Ohio. We now have over 200 community-based organizations, over 400 programs. What's good about this in Northeast Ohio is that the two largest healthcare systems, the Cleveland Clinic and University Hospitals, both agreed to use Unite Us as their electronic resource referral platform. So hopefully we are going to avoid in the social care space what happened in the EMR space back in the day when everybody had their own EMR and none of them talked to each other. By all being on the same electronic resource referral platform, it gives us tremendous possibilities to look at our data and scale and act on that. This is what we're hoping will happen as a result of the Unite Ohio network. I won't read that to you, but I will say that in the state of Ohio, our electronic, it's called Clinic. It's like the statewide electronic health information exchange is now going to set this sort of process up on a statewide level and is going to use Unite Us as the network. So more to come in Ohio. What we're trying to do with the referrals is to sort of streamline some ways that we can react to them so that A, people aren't waiting so long for an answer, and B, we're not overwhelming our limited staff response to this. We use mostly community health workers to respond for folks with multiple health-related social needs. So this is not exactly accurate, but it gives you some idea that we'll refer some needs to a community health worker. For food, since we have a robust food distribution network in Cleveland, we can make automatic referrals for that. These should all be coming off of this circle. If someone needs internet access, we have internet connectivity providers we can directly refer them to. People who report a risk for intimate partner violence are contacted in person in 1 to 2 business days through our trauma recovery center. And people who have who report issues around social isolation, physical activity, or stress, right now we're dealing with that by sending them educational material automatically. We'd like to get a little more involved in that, but that's what we have to offer right now. And for folks who have a lot of different issues, we try and pick them up with. My experience with this has been the community health workers are really the secret sauce for responding to these health-related social needs. They know their communities. They develop relationships with the community-based organizations. They gain the trust of their patients. They're really, really invaluable. And I think as we try and revolutionize the healthcare system, figuring out how to get community health workers paid for the work that they do, I think would make this so much more robust and make our healthcare system so much more effective, in my opinion. This is what we're hoping will happen if we address these health-related social needs. At the end of the day, we are a healthcare system. We're not a community-based organization. So our ultimate question is, will this impact people's health? Will this make people healthier? Will they utilize healthcare services more appropriately? Those are kind of the bottom line issues that I think the healthcare system is going to be interested in getting into this space. These are the referrals we've made as of early August. Food assistance, far and away, is the most common one. I think that is in part a reflection of the supply of what's available in Northeast Ohio. Dealing with food insecurity is relatively straightforward. Dealing with housing insecurity, not so much. Like everywhere, Cleveland has a horrible affordable housing crisis. And rents are going up, utility payments are going up. So when people are in that situation, frankly, there isn't a lot we have to offer right now. We have some services. Unite Us also has its own reporting system, and so they can report on the referrals they're seeing, as well as us doing our own internal reporting. And this is some of the data that they give us, so we can really get pretty granular about who's getting referred for what, where, what's getting resolved, what's not getting resolved. And obviously, if you're going to make a referral, whether it's electronic or in person, you're hoping that the person will get what they need. Otherwise, we've wasted everybody's time, right? We wasted money. So we're really interested in what are effective referrals. So, as I mentioned, we're really dedicated to both research and evaluation. I think there's a lot of potential here for the information that we are collecting to drive policy change. If we can, identify gaps in the human services network, and we can support them with robust data, I think that presents a more compelling picture for policy change. Although I will say in Ohio, not optimistic right now. This is some of what we can do with our own information. And as I mentioned, trying to link the health-related social needs with clinical utilization data. We found that people who are socially isolated have certain medical diagnoses that are more common. They have utilization risks. They have other associated health-related social needs. And again, as I mentioned, social isolation was not just a phenomenon of the pandemic. It proceeded the pandemic. Here's a look at people who report housing insecurity. And you can see why a healthcare system might be interested in this, because people who are housing insecure are more likely to use the ED, and they're more likely to use the ED for things that could be dealt with in another setting. So, as a healthcare provider, that becomes quite expensive. So, all these right now are correlations, right? We haven't proved any causation, we've just demonstrated correlation. And so the next step is to say, okay, if someone's housing insecure and using the ED more than would be ideal, if we address their housing insecurity, does the utilization pattern change, right? It's like if someone who has diabetic is food insecure, if we address the food insecurity, does their diabetes get under control? Those are the correlations we're looking for as a healthcare system, and that we're just at the beginning of starting to understand. And again, this is another look at food insecurity. This is, I invite you to look at the slides for details. This is just a way of correlating health-related social needs with clinical utilization data. Again, trying to demonstrate impact in a way that matters to the healthcare system as well as to the patient. And I'll show you one more, which is health-related social needs cost a lot of money. And you can see the excess costs associated with unaddressed health-related social needs compared to folks who don't. And again, talked about how we're using data. There's lots and lots of potential, lots and lots of possibility. Like I said, we've only started to scratch the surface. If you're interested in hearing more about this, like I said, I'm hosting a breakfast table tomorrow. We talk about how to do SDOH screening in the primary care setting. I'm also doing a seminar tomorrow afternoon where I'll look more at the United Ohio Network side of it as opposed to the screening side of it. I'm happy to talk about this with that. I believe I'm done.